Hi, I'm Brett Beckman, board certified veterinary dentist. Welcome to the Vet Dental Show. Our veterinary dental practitioner program registration officially is November 12th. On Sunday, we're going to be doing a live training at 10:30 a.m. Eastern. As podcast listeners only, and this is only for podcast listeners, and this is only for our past wet lab participants, the last 2 times we've done wet labs. If you go to ivdi.org/2024, we've got something special for you there to secure your spot in the class of 2024. There's only 48 veterinarians that will be able to be in that class. And by securing your spot, you'll also get a considerable discount on your tuition. So again, visit ivdi.org/2024 and all the information's there. We hope to see you in that class.
Let's discuss today a really common problem that we see in general practice. This is important to everyone in the dentistry suite, and it's important particularly for the patient and for the pet parents. And that is palatal trauma from the mandibular canine teeth in puppies, particularly the deciduous teeth that are impinging upon the palate. The canine teeth are the most destructive, obviously, because they're like little swords that are digging their point right into that soft palatal tissue and causing pain. In the exam room, many times these puppies don't want to be evaluated. You can do an exam and be pretty thorough and not without much resistance from the patient in other areas of the body. But when you start to get up to the head, they are very reluctant to allow manipulation of the muzzle just because they associate that with pain every time they close their mouths, especially when they're chewing or they're playing and they bite down and there's nothing in between the back teeth to stop the trauma from biting down fully, and that full force hits that palate with those canine teeth. So when we see these in practice, we want to do something about these yesterday. And so there's an urgency there for the patient. Once the pet parent's aware of what's going on, it becomes an urgency for them. They may be the ones that pick it up initially, but usually they're not. Usually this is seen as an incidental finding during examination. And in general practice, we need to be looking for this with puppies that are 6 to 18 weeks of age or older. Even after the adult canines start to come in, this can still be a problem, and it can result in malocclusion of the adult canine teeth. So we want to catch this as early as we can. And this can result from a narrow mandible, just from a conformation standpoint. Base narrow canines is a term used for that. It can also result from malocclusion, where we've got a class 2 malocclusion where the lower jaw is shorter than the upper jaw and consequently causes those rostral teeth to sit further back in the oral cavity in general and further narrow into that widening upper maxilla, and where they wouldn't cause problems if they were between the deciduous canine and the deciduous incisor in the maxilla. If you move further back, if you think about it, that gets wider in the maxilla. So a narrow mandible moving back wider due to a malocclusion is going to cause the same thing. Doesn't matter what the reason is, the approach is to get that taken care of as soon as we possibly can. And for those of you who are watching this on YouTube, we've got a couple of slides that we have that we can demonstrate that, but I can also walk through this with audio on the podcast very easily. Everyone has seen what this looks like, where that lower canine may be in varying stages of contact around that upper canine. It may be rostral to it, maybe actually contacting the palatal edge of that canine tooth where it goes into the palate and causing trauma to the upper canine tooth, or it could be as far back as behind or caudal tooth the upper canine tooth. So there's varying degrees of where that sits, but the bottom line is we've got to do something about it. And preferably we want to do something about that now. We want to do something about that today or tomorrow, depending on the situation, depending on the practice and pre-op blood work and everything that involves an anesthesia procedure in any particular practice. So as soon as that can be scheduled, we want to schedule it. Analgesics are probably not going to be of much benefit, but we definitely would recommend analgesics in the interim just to provide some theoretical relief to this. And the approach to this certainly depends on the operator. If you are in general dentistry service in your practice and you do quite a bit of dentistry, you've done this procedure before and have experience with it, it's certainly something that you can consider removing those mandibular canine teeth and possibly the maxillary canine teeth. But there are a lot of reasons why we would or wouldn't remove the maxillary canine teeth, depending on the occlusions. We're not really going to go into that at this point. What we're going to do is we're going to concentrate on getting that pain resolved. Varying conformations in different individuals that you're going to see in their puppyhood where this is a problem, and it's a big problem. So the other thing that we need to consider when we look at the canine teeth, they are the point of maximal contact with that palate. So if you open that mouth and you look at the palate, if that puppy will allow that, which is probably not going to happen, but if you have that opportunity to do that and take a quick glance in a good light, you will probably see that there's contact from the 6 little daggers that accompany those swords that are the mandibular incisors. And even if those are not contacting at the time because the canine teeth are causing such a dramatic impact and actually preventing the lower incisors from contacting the palate, once those bottom canines are removed, then those incisors become the point of maximal contact. In that respect, we've got to not only remove the upper canine or the lower canines, we have to remove the lower incisors as well. And those lower incisors are very short, but their roots are tremendously long. When you think about removing your mandibular or maxillary decidual teeth in dogs and you look postoperatively at the length of that root compared to that crown, it's probably about 3 times, maybe 4 times the length of the crown. So the root is a lot longer. It's about the same diameter as the margin of the crown to the apex. But when you look at those incisors, that's a different story. And you would be surprised to see the root of that incisor is about the same diameter as the crown, maybe a little bit less. And it's about 10 to 11, maybe 12 times the length of the crown of those incisors. So they're uncharacteristically long if you've never seen them. If you're watching on YouTube, you're looking at a picture of such right now. But that being said, those are able to be extracted by people who have experience and that have a lot of patience and that have good, sharp 1.2 to 1.5 luxator elevators and or 16, 18 gauge needles on a 3cc syringe where you can go down in around the periodontal, around the root through the periodontal ligament space between the root and the bone and start to loosen those up. But you really have to be careful when you go to extract these. If you're not comfortable with that, and those incisors are a problem as well, which they almost always are, then consideration for referral for extracting those incisors may be in your best interest. That being said, if you know for sure that they are causing problems and or that removing those lower canine teeth are going to cause trauma and you're not comfortable extracting those incisors with those very long, thin roots, then you want to consider referral for those. And Endodontic problems and malocclusions, for the most part, are difficult to assess. They are multifaceted, and the patient's growing all the time. We have a lot of considerations as that patient gets older, and after the procedure is done correctly, whether the adult canines are going to genetically be predisposed in that particular patient to come in normally or not. So not only do we have that trauma, we're going to back up a little bit here. Not only do we have that trauma from the standpoint of pain, we have that trauma from the standpoint of a physical impingement to the normal movement of the jaw rostral during development. That caudal part of the mandible is where the growth plate is, and the growth occurs from that point forward. And so that lower jaw may be being prevented from moving forward by those deciduous mandibular canines just from a physical impingement, causing bowing of the mandible with further growth versus forward movement, as long as those canines are there, and in a lesser extent, as long as those incisors are there. So if we do have a canine tooth on the lower that is not quite where it should be, it may be a little bit further back than it would be normally between the canine and the lateral incisor in the upper, a little further back adjacent to that canine, but not too far, we may get normal jaw movement if that patient is genetically predisposed to that, so that the adult canines don't have that problem. But the owners always need to be instructed that this is not just a problem with our deciduous teeth. It's also potentially going to be a problem with the adult teeth. So at 5 months, at least, we want to get these patients in, look and see what those adult canines are doing. We can't predict really exactly where they're going to end up, but we can see where they're coursing and follow those every couple of 4 weeks until the adults are in. And if once they are getting to the point where we know that there are going to be occlusion problems, that is definitely the time that you should consider referring these to a specialist to have that evaluated and that corrected. Hopefully this has given you a good overview of that problem and how much of a problem it actually is for the individual patients. It's very important that we catch this early. It's very important that we are competent in removing those teeth. And I will add this as well, having good, sharp luxator elevators and or a periotome are absolutely essential when you're removing those curved deciduous teeth in dogs especially. Dr. Betts Pets has a deciduous extraction set on that website and many other things that you need in general practice in your dentistry service that we use, that we recommend. And all of our students that have had those are very happy with the results. They can get out very much quicker than they would normally and without fracturing those teeth, just because you've got a convex and a concave elevator. And with that concave and convex elevator, you can accommodate the front and back or mesial and distal aspect of those roots. Keep that in mind. And if you are doing those now and you want to get quicker using the periotome that comes in that set and those two luxator elevators, make it a lot quicker. Do these again with urgency, and you'll find that your patient is so much more comfortable, and you also give the patient a chance for a normal occlusion when those adult teeth come in. Thanks for listening. I really hope you love that episode of the Vet Dental Show. Again, if you're a veterinarian and you want to be the best in dentistry and general practice that you can be, we've got something special for you at ivdi.org/2024 to be part of our class of 2024, one of 48 veterinarians to get into that class, and you'll secure your spot early before the November 12th training that we have to make sure that you're in that
group and make sure that you're off to the races as far as building your skills and your dentistry program in your hospital.